the complete story. 12. Remember, the management may be so simple. Let us see. A 57 years old male patient admitted to ER because of dyspnea, desaturation, and hypotension. The lethal triad in RR. Autosaturation 89 on a liter face mask, blood pressure low 78 over 45 on levofit 10 mic per minute, heart rate 100. The primary assessment was dilated cardiomyopathy, pulmonary edema, and the diuretics inobrettor started, noradrenaline. I was called to see the patient for assessment by critical care ultrasound. For first, inferior vena cava really was impossible to see from subcostal view. This patient has very bad window, impossible to see in subcostal view. I started by parasternal view. As you see here, there is pericardial effusion here and here, right ventricle, left ventricle, there is pericardial effusion. You can say moderate pericardial effusion. Contractility is not bad, really. Contractility is not bad. Visual assessment, you can say 50% ejection fraction. It's not bad, not so bad. Okay. Pericardial effusion, moderate, and good contractility, hypotensive patient. What else? Subcostal view. Really, the most important view for this patient was subcostal view. As you see here, still pericardial effusion, moderate pericardial effusion, and as you see here, collapsing right atrium, really, as you see here, right atrium is collapsing, really. What's going on? This patient, good contractility, moderate effusion with systolic collapse of right atrium and hypotension. What are you going to do for this patient? What's causing hypotension, really? Oh, very tricky. Okay, let us see. Before thinking about any deloading of the pericardial aspiration, please go to physiology. Here is the physiology. This is the mitral valve flow of the pulsed wave Doppler. As you see here, it is marvelous. It's good. It's completely normal. In pericardial tamponade, you expect 25% respiratory variation of the mitral inflow tract. So this patient has no tamponade physiology. This is very important. What else? What else could be beneficial to this patient? Please, if it's impossible to go to subcostal view, please go to the liver. Try to get a hint about inferior vena cava. What's going on in inferior vena cava? You can get it from the liver, because liver is very good window to see inferior vena cava through. Let us see. Oh, aorta, big aorta occupying the lateral view of the liver. But with manipulating the probe, you can see this beauty inferior vena cava with valves inside. You can see the valves inside and the collapsibility of the inferior vena cava, and this is the aorta. You can just manipulate, tilting your probe medially and laterally to get the aorta and inferior vena cava. And this inferior vena cava really is collapsing, and there is valves inside. So you now get an impression that patient is hypovolemic. It's very, very important piece of information at that time. Okay, let us confirm that. This is the M mode of the inferior vena cava, as you see here. The valves, these valves inside, and it's collapsing. It's collapsing inferior vena cava. This is the aorta. This is inferior vena cava collapsing. This is a valve inside. Can differentiate between inferior vena cava and the aorta. Here you see this is a valve and this is the inferior vena cava. So it's very important here. We get very important piece of information. The patient is hypovolemic and good contractility, and he is moderate pericardial effusion, but no tamponade physiology. So again and again, it is an integrative approach. It is not only the inferior vena cava, it's not only the pericardium, it's not only the myocardium, it's not only the two-dimensional, it's Doppler, flow, it is inferior vena cava, it is multi-integrative approach to get your decision in proper way. So, no evidence of tamponade now, inferior vena cava is flat, and no tamponade physiology on mitral inflow by pulsed wave Doppler. What's missing? Good heart, no tamponade, hypovolemia, and desaturation. The most important organ now in multi-integrative approach intensive care, ultrasound. It is the lung. Here is the answer of our questions. The patient has lobar pneumonia. He has air bronchogram in the right lower lobe. He has infiltrate, B lines. So our patient very simply has pneumonia with sepsis and the hypoperfusions and the hypotension. So now it's clear our patient has pneumonia, which is the main precipitant of all complaint, desaturation and hypotension, and already simply patient needed IV fluids and antibiotic. Blood pressure improved a lot by inferior by IV fluids. So please, if you see pericardial effusion, if you see even systolic collapse of the right side, maybe because of hypovolemia, you may get systolic collapse of right atrium and even right ventricle by hypovolemia because the patient is empty. So please, it is a multi-integrative approach. You should get your decision after approaching all aspects of critical care ultrasound. And thank you for appreciated listening. See you in the next complete story. Bye.